Fantastic. Okay, so good evening. Welcome everybody to our webinar this evening, where I have the great chance to interview Glennie, who is from Stornoway in the Northern Islands, Scotland. And we'll get into that story in a little bit. First of all, let me say welcome everybody. My name is Mark Davis and I'm Director and Principal at the UK College of Hypnosis and Hypnotherapy. And we offer this training program called Diploma in Hypno-CBT, Cognitive Behavioral Hypnotherapy. And people have the chance now to take that from around the world, because we moved away from teaching live in person to doing live broadcast on Zoom, but also to creating what's called a flipped classroom model, where you also can watch the lectures in your own time and then come for one-to-one tutoring. But what both these formats mean is you can train and qualify from anywhere in the world. And so we can disseminate this particularly interesting, powerful, flexible, but also systematic model people can get trained and qualified wherever they are in the world. And for me, that's a joyous thing. And I hope for people taking it, it's a joyous thing. So now, Anne, could you give us before I dive in, and what I'm going to be doing is asking Anne about her journey, and then an experience of getting trained and set up. And then we're going to dive into the particular topic this evening, which is working with chronic pain, with a presentation from Anne and questions from you, and probably from me. We'll be interviewing Anne about that. But the first part, we're going to do a little bit about Anne's journey. But Anne, would you give us, first of all, a little snippet intro?
A little snippet intro, that's tricky, but essentially it's almost exactly 2 years ago since I discovered the diploma. And from the moment I discovered it, it was like a oh moment. I literally almost cried because I couldn't believe this was possible, that I had found something that would enable me to work one-to-one with clients and I wouldn't have to go and do another degree, which I certainly didn't have in me. So it's hard. I can't do it short, but basically it's this whole thing started, 2 years ago in the August was when I found it. I signed up almost instantly when I came across it. And I started in November 2023. And I've ended up eventually focusing on chronic pain. So I describe myself as a chronic pain therapist, but as you'll see tonight, I'm using all of the tools that we've learned in the diploma to use with my clients. That's what I'm using. You'll see my key interventions and how I go about putting them into a kind of loose treatment plan.
Fantastic. Well, let's just roll back there. Thank you so much. And I'm so excited also we have somebody who's deciding to specialize in working with pain and chronic pain, because I keep encouraging that. And not enough of our sort of trained therapists are going into that. I do want to kind of see why that might be. I've got a little theory around that from my own hesitations, perhaps, of doing this. I want to get into Anne's work on that. Before we do that, though, let's roll back time, Anne. I mean, before you were looking at this, what's your background? What were you doing professionally? And then what was that kind of decision turning point? And I do remember your student application form, and it was very emotional to read it. It was beautifully written as well. A little essay about how powerful this was for you, that you could train up there in the Northern Islands in Stornoway without having to go and do a degree or travel anywhere. But let's roll back time. What were you doing before? And then how did you come in to decide to take this sort of route?
Well, my background is in teaching, although my degree was English and theology, and I thought I wanted to teach English and religious studies. That's a whole nother story. I eventually ended up in the primary classroom because there I can do a bit of everything, and loved the classroom. I've been in education for sort of 20 years before I changed to do this. But for the last sort of 13 years of that, I was working as a literacy consultant. So I was based here in the Isle of Lewis, and I was travelling from the Isle of Lewis to Scotland, to the mainland, regularly to train teachers, mainly in literacy. So teaching teachers, essentially, how to teach reading. And that shouldn't really have been my job. That should be covered in teacher education or teacher training. But essentially, I set up my own, consultancy, my own business to do that and carry out that work, which I loved. And I loved meeting teachers. I loved passing on that knowledge. I loved making sure that what we were doing is the most effective practice based on the latest research.
Because literacy is important, isn't it?
It's everything.
It's everything, yeah.
Couldn't do any of this. Couldn't do anything I've done in my life if I hadn't been taught to read.
But I mean, in terms of outcomes for people, their literacy is really important, and getting that reading in early, that reading ability early.
You can't access the curriculum if you can't read. You can't read for pleasure if you can't read. The world is closed to you if you can't read. Like literally, like I can't, there's nothing more important. And I mean, don't get me started on this, but in my opinion, like we've got 7 years in primary to teach children to read and to help them to love and enjoy and access reading, whatever type of texts float their boat. But it's a lifelong gift. It's the gift that keeps giving. And if you want to learn, you have to be able to read. If you want to get on in life, you have to be able to read.
I
So,
can't remember all the data on it, but I mean, when I was interviewing Don Meichenbaum, and he's done a lot of work on that actually, and I think impacts on not just income levels, but prevention of violence and all sorts of things like this related to literacy.
oh gosh, absolutely. I mean, some people talk about, the I don't like this phrase, but school to prison pipeline. But basically, if you look at a prison population, you're looking at sort of 60% if you can't read that are in prison. 58% lack functional numeracy. So the basic skills that we're responsible for in the primary school, they dictate life choices and life chances.
So this was high impact work you were doing in Scotland, and then you decided to to stop doing it.
I loved the work. I didn't love the travel. And the work morphed into campaigning really to change the way reading is taught in Scotland because we're not exactly following the research, even though I'm going out and trying to spread the word. This is slow work. It's one school at a time or a cluster of schools at a time. Whereas this needs to happen at the root, it needs to happen at a system level. So I was fighting the system. And that's what took the toll as well. So I'm like, okay, I'm telling people the same things, but I'm essentially hitting my head against a brick wall. So that was what was giving me the feeling of maybe this isn't the right thing for me anymore. I was also, now in hindsight, and also having done the diploma, I can realise and see I was taking it all personally. I was almost carrying that burden of no one knows about this, so it's my job to tell everyone about it. And teachers within the profession can't speak out because they're afraid of losing their jobs and they're being told you can't speak out in social media. So I'm like, well, I'm sitting here out with the system. I'm one of the few people that can speak out without fear. So it became like a personal mission.
That
And
must
then
have taken an emotional toll on you then, though, when you couldn't deliver on that because the system's so stuck. Yeah.
absolutely. And it took me quite a bit to let go of that because it's still badly needed. And in the diploma when we're doing our practice sessions and we're working on, our little issues, that would often be something that I would be bringing up, that kind of moving into a new sphere, moving into a new career, being able to let go of something that had become very much fused with my identity.
So how did you come to make this shift into deciding to be a hypnotherapist?
Well, I'd been doing a bit of reading around things. Essentially, in the summer of 2020, my sister booked, I don't know what the right term is, a fortune teller. And the fortune teller said, "Have you ever done Reiki?" And I said, no, I've never done anything to do with it. And she said, "I think you should." And she also talked about a tortured mind. Do you know anyone that's got a tortured mind? And I'm like, no, absolutely not. And eventually she said, "It's you. You're the tortured mind. You've got so many things going on in there." So I suppose that was a bit of a realization that I needed to make room. I suppose that was the phrase I had in my head. I want to make room in my life for other things. Because at this point, I'm traveling, I'm training teachers, I'm fighting this kind of campaign, but also in 2016, I'd started a publishing company. So I was doing two jobs, two full-time jobs and traveling. So it was now starting to get to kind of critical levels like, okay, I need to really do something here. And I was really trying to research into Reiki. I was trying to find some kind of substance to it. And it wasn't there. And I couldn't tell anyone I was doing this because it was such a mismatch between Anne, who's going around telling everyone, you must be research informed, your practice must be evidence based. And I'm looking like it, and I'm like, this just, while it did provide me with a personal meditation practice, and I still use that Hatsuri whole Japanese meditation, the substance wasn't there for me. So long story short, I was doing this research, came across a name of a person that I thought had been to Japan and trained with one of the original masters. And they were using Reiki and hypnotherapy. And I was like, ah,
Hmm, interesting.
that's what started the. So I'm like, let me look at this. And then, bing, okay. And it was like, ooh, oh, like a gift. There you go. You've been looking to make room, you've been looking for something, but you didn't know what. I wasn't, actively looking to change career or looking to train. But when this presented itself, it was just like, okay, this makes sense. And honestly, yes, it was exciting. Yes, it was going to give me a solution. It was going to enable me to continue to be self-employed. It was going to allow me to do it from here on the Isle of Lewis. But more than that, it was credible and it was research informed. So straight away, there's my biggest box is ticked. It's going to give me a credible qualification. I can have professional registration. And that's why when I found it, I was like, there was like no doubt in my mind. It was from the moment I found it to signing up, been paying my money, it was less than a week.
And that's not just the field of hypnotherapy. That was particularly finding the UK college, yeah?
When I talk about hypnotherapy, like this was a quick thing. It was like, let me look. And it was the college diploma. Ooh,
Well,
you know,
we do come up quite well on the search results, and we'll talk about search engine optimization in a little bit because we were just talking about that, Anne and I. So you found us by searching on Google, and then up we popped, and then it was you saw the fit there. Lovely. Well, yeah, and I mean, and also just this idea, you're a lover of language, right? I mean, that's what you do. You go to publishing. You have a mission to do literacy in Scotland, and of course, was that something you recognised as well? That this aspect that hypnotherapy is this route of using painting pictures in people's imagination, creating worlds in people's imagination with words.
at that early stage, I probably didn't recognize that as much, but very quickly, because I'd never had hypnotherapy, I didn't have any personal experience of it or what it involved. So I suppose only once I started the diploma, I'm starting to realise not only does it tick all of these boxes, but it's bringing in this element of language, of creativity, of not just using words to entertain or to inform, but actually using words to change people's lives, like almost writing a spell of sorts. And so that appeal, that craft, and also the fact that you can craft this over a very short piece of writing, that really appeals because it's then very accessible, and almost, if you want to, You can be very poetic about the language. You can take your time choosing the right words. You can have alliteration. You can look at the flow and the rhythm and the repetition. So yes, that aspect definitely appeals as well.
So this tie-in, which we were discussing earlier, and is in that chapter of the book there, with rhetoric and classical rhetoric, in terms of being able to deliver a noble speech that moves hearts and minds and has people take action.
And it's funny, and I love the phrase that it talks about, a therapeutic story with a happy ending. That really resonated with me. And in the book, they talk about healing being a form of persuasion, obviously using that rhetoric, that persuasive language. But what struck me was the parallel with teaching, because I used to describe teaching as being in sales. Because in the classroom, you are persuading everyone to come on the journey with you. You're persuading everyone that this thing we're about to learn about is so exciting. And when we do this, you're going to be able to do that or whatever it is as a result. So you're trying to bring the children with you on a journey to motivate them, to persuade them to, be motivated and give their best on that journey with you.
That's so interesting. We just, she'll put the book up and I'll type it in here. Third edition. Yeah, by Jerome Frank and his daughter Julie Frank. But I came across this book. Somebody had mentioned it to me, and then I was watching a YouTube video with Dr. Alan Francis and Professor Marvin Goldfried. Alan Francis is probably the kind of the dean of American psychiatry, who sat on the chair of DSM-4, for those that know that process of creating the Diagnostic and Statistical Manual of Psychiatric Disorders. So he headed up that process for the fourth edition. And then also Professor Marvin Goldfried is helped create some of the early CBT, particularly problem-solving therapy, and has continued to do research into therapy in terms of particularly creating sort of trans-theoretical approaches to psychotherapy. Really interesting work. They're having this discussion, these two old guys, actually, and they were saying that this book was the most influential book they read, even more important for them than Freud or anything else. And I was like, well, damn it, I better get that book and have a look. So that's how it's on our kind of getting onto our reading list. Really interesting in terms of seeing all psychotherapy fundamentally as a process of persuasion, which sounds sort of strange, but once you start to read it, you see the depth to that and its relationship, therefore, to rhetoric, giving a powerful, influential speech. And then when it comes to hypnosis, the chance to kind of deliver that kind of just times 10, because the whole point is they're a completely willing participant in this story that we're painting for them with our words and experiencing it strongly. So yeah, really interesting book and very, very intelligently written as well. So not the quickest read, perhaps, because it is so rigorous and thorough. But Anne, so tell us, let's just go through. You decide to sign up. What was it like? Quick summary of what taking the training. What were the highlights? What things stood out for you?
I loved everything about the training. I did the webcast and I did it actually fairly quickly. I was able to start in November 23. I think I did stage 1 and stage 2 in the November and stage 3 in the December. So it was all it was really quick, really quick.
The real fast track, yeah.
Yeah, super fast track. But that was another thing that, attracted me. I'm like, wow, I can actually, if I put my mind to this, I can actually knuckle down and do this really quickly. So that was huge. Loved the webcast format. Loved the opportunity to do all the practice sessions every day, because that's the moment when it's like, okay, I can actually do this. And I do still remember the process, and I remember like some of my fears starting it seem really quite silly now. I was thinking, maybe a man's voice is better for this. Maybe a nice, deep, relaxing voice. Will people want to listen to my little squeaky Scottish voice? Really stupid things that I was thinking. And in the event, all of that falls away and you're like, oh gosh, I can do this. But I also remember the fear, like very early on, in the practice sessions, it would be something along the lines of, okay, now just do your own emerging, or now just do your own, just off the cuff, your own induction. And I'd be like, what? No, I'm not ready for that yet. But you very quickly get there. You very quickly are ready. And, even towards the end, doing some of the online practice sessions that we have to do, and I'd be, paired up with someone who'd maybe just started, and they were saying, oh my goodness, how are you able to just do this? And I'm like, listen, I was like you, like literally a few weeks ago. I said, but this takes you through all the practice sessions. It will get you where you need to be, and your confidence will gradually build.
I remember, yeah, when I took the training myself, and then I shadowed Donald Robertson several times, and he would say, it's like, okay, it's like you're on a bicycle and got the stabilizers. We're going to take the stabilizers off now, and it's going to wobble a bit. But as people did the script writing exercise, or did their own emerging or their own induction, but it is put together really cleverly in terms of building your confidence and skill step by step, and then by the end of the week, you're off and running and you're cycling on your own, right?
Oh, absolutely. I did love the structure of the course. And even still in my mind, the structure has enabled me, there's almost compartments in my mind, stage one, stage two, stage three, even down to some of the days, particularly in stage one, obviously for me, pain day, day 7, really stands out for me. And that was a big clue for me. And I should have paid more attention to that, because day 7 for me was my really biggest hypnotic response, where we had to do the experiment where you put your hand in the frozen water. And I honestly couldn't even last 10 seconds when I first put my hand into the water, and I was laughing and like, oh no, I can't do it. And then when we did it the second time under hypnosis, we actually, I don't know what happened, lost internet or lost volume or something, but my partner was saying, Anne, come back, come back. And it was like way over a minute and a half. It was over the time we were meant to do it. My hand was still in it. And she's like, are you okay? Are you okay? I was like, what do you mean? She said, you're way over time. That was way over a minute and a half. And I'm like, really? And she said, yes. I said, I will never believe that. I said, that felt like at the very most 30 seconds. So that for me was a big moment of, wow, look what this can do. And I mean, pain for me, you might be wondering why choose pain. Well, I've always had an interest in pain. That sounds a bit strange, but all of us in our lifetimes will have experienced pain. Like I was born with a club foot. I had lots of operations when I was young, and I can remember being 4 and not being able to sleep, and because I had pain in my leg. And there was nothing causing that at the time. I'd had all the operations, it was healing. So pain's been there in my life for various things, but also when I was describing earlier, I'm doing 2 full-time jobs and I'm traveling. Pain decided to make a big appearance in my life. And I started to have unexplained pain. I started to have sudden electric shock type pain, sort of in my arm. And I also had lower back pain that was traveling down into my leg. And I was like, something's wrong with my back. I was traveling around with a giant, like 25-kilo suitcase with all of my resources. And I'm thinking, it's because I'm pulling this case all around Scotland that I'm in pain. So, of course, I end up seeing the doctor. The doctor's like, I want to give you some nerve painkillers. I'm like, well, don't really take medication. And she's like, you're going to need this. Just take the prescription anyway. I was like, but it's okay just now. But the kind of message was, this is going to get worse. So as we all know now, or those of us doing the diploma, with our suggestion, like you're basically telling me this is now going to get worse. So it gets worse. And I end up becoming a person who never forgets their medication, who will wake in the night suddenly like, I've not taken it, I need to take it now. And that was a big change for me, but I was lucky that the medication helped. But during this time, I had to have MRI scans, brain scans, nerve conduction tests, to get to the bottom of what's causing this pain. But in the end, nothing was causing this pain. They could find no structural cause. And in 2020, when COVID happened, that was a good thing for me because all of a sudden all of my work went online. And that travel that was so difficult was stopped. And gradually after that point, I was able to come off all of my medication and my pain went away.
Mm. I mean, that's so this when you do the day 7 and you're starting to see and experience, and I assume it wasn't just that you experienced, that also then as a therapist, you were able to facilitate probably a fairly considerable change in pain for the person you're working with. As you see that, what is the impact of that for you, for somebody who's had quite a strong and recent history with pain?
It's funny because I wasn't joining the dots at all at that point about my experience. It's almost like I'm not in pain anymore. It was in the past. It's far away. But certainly as a therapist, when you're doing it to the other person and when you're facilitating that, it is miraculous. Like I've had a client where they had trigeminal neuralgia, which is one of the most painful conditions you can have with face pain. And, they're coming to session starting up at sort of an 8/9. And then you gradually watch them getting down to like a 2. And they're starting to almost fall asleep. And I remember saying to this person, are you okay? Would you like to go to sleep now? And she said, yes, I've never been able to just drop off because the pain's never been that low.
It's interesting, isn't it?
And I'm like, just go to sleep. We'll pick up next time. So yeah, there's something miraculous. It does feel magical. And we know it's not magical. We know the research is there and it supports it, but it feels magical when it's happening.
How important though was, when we do that pain control module, we emphasize that you must experience this. You can't just read about it and read the research. You've actually got to experience for yourself pain changing and facilitating that for somebody else to give you the clinical confidence.
Oh, you can't overemphasize how important that was. Like, I wouldn't have understood it. I wouldn't have really believed it if I hadn't seen it with my own eyes. You have to experience it. I can't see any other way. You can read about it, and but people will, even people you're working with or telling about it, they'll still have this sort of almost a healthy skepticism. Like, how can that work? And working with clients, one of the videos that were shown in the diploma is of the Scottish dentist and a lovely Scottish lady going to have her teeth out with no anaesthetic at all, just purely with hypnosis. And I've used that with clients to show them, look at what's possible. We don't need to do that, but look what we can do. And it just sort of, you're opening that door of, I know this sounds a bit strange, but it's entirely possible.
So important to do all that prep work, change expectancies, and loosen up kind of perhaps quite rigid ideas about pain, and so the possibilities are there. The possibilities are there. So let's find out. You did that. I mean, we could talk about more aspects of taking the training, but let's just find out. So you finished the webcast December 2023. You plowed ahead. I imagine it sounds like quite quickly with getting your assessment and case studies done.
I did. I really tried to just push everything forward all at the same time. So, case studies, questions, just do everything that needs to be done, my supervision. I had kind of in my mind, I wanted to have everything submitted by the end of January, but I got COVID and Christmas got in the way. That's my excuse. But I had everything done and submitted by the end of February 2024 and got my diploma a month later, just before my birthday.
When's your
So
birthday?
birthday's 25th of March. So when you ask us in the diploma, okay, are you committing to a date here? When are you seeing your first client? And I'm like, let's put my birthday down. I'll put my birthday down. So birthday's 25th of March, and I think I got the diploma on the 26th. So I wasn't far away.
Wasn't far away. The importance of setting goals, huh? The importance of setting goals. But just for everybody who's listening in there, both those who are thinking of training with us, but also those who are already training. So basically, having finished the training component in, I think, about 10th of December, around that time, 12th December, you're qualified January, February, just over 3 months later. And the whole process has taken less than 6 months. So yeah, it's entirely possible, everyone. And if you don't have Christmas and COVID in between, it's possibly to do it more quickly.
Oh,
Um,
you could definitely do it more quickly because I had a wee mini work project in there as well, and yeah.
Fantastic. Okay, well, I hope that's really inspiring for people. Any tips there on getting the assessment and case studies done before we proceed on and kind of find out about your practice?
I had gleaned an awful lot of tips from, and it's really funny to be doing this actually because I found all of the early interviews really helpful. So I think, is it Marguerite
Or
Alcock?
Marguerite, who did the whole thing and like was qualified in 6 weeks,
Yes,
something
I'm like,
crazy.
wow, if she can do that, right? Okay, so that inspired me. I'm like, okay, I can do the same. That was my kind of idea at the time. But she gave really good advice around, do your questions straight away, scope them out. So I did. I had a Word document, one question per page. As I went through the training, I'm just making the occasional note. I know that's coming up. There it is. Or if it was in my slide handout, I was doing a big box around it, like, come back to this. This is appearing in the assessment. And I think probably the thing that made the biggest difference was doing the first 6 questions as soon as I finished stage one.
Yeah, yeah.
It just takes away, it's not a mountain to climb anymore. It becomes a lot more manageable. And then just tackling the questions in that, not the numerical order, but in that sensible order of these are the ones that relate to hypnotherapy in stage one. That guidance that's given, follow that. And that just makes it a lot easier. And by the time you're getting to the end, you've broken the back of it and it's actually much, much easier. But yeah, I kept everything moving forward and I had a big kind of dashboard, I suppose, that I created on Microsoft OneNote. So I could see at a glance my case studies, how many sessions I'd completed with a client, which questions were ticked off, how many sessions of supervision I'd had, like all on one thing.
You got
So
it.
that
Sorry,
was,
your mission control view there, yeah?
yes, and that was motivating because I'm able to tick, tick, and it's, okay, we're just gradually chipping away.
Fantastic. Did you use any of the support sessions or drop in for any Q&A assessment with Tim? Sometimes he does some, or Louise.
I didn't actually know. I did lots of practice sessions and I
Okay,
went to all the webinars. I went to all of the extra things. But I managed to just chip away on my own with the questions. And
fantastic. Well, brilliant. Well done. And so, launched your practice. When did you see your first paying client?
so got the diploma at the end of the March. In April, I went to a Royal Society of Medicine webinar and I only knew about it because I think it was Sue that had mentioned,
Hmm.
oh, it's really good if you join them and keep an eye on what they're doing. So, okay, I'll have a look at what they're doing. And they were doing a webinar on hypnotherapy and oncology as well was one of the things. So, using hypnotherapy in cancer treatment. So, went to that. I thought, gosh, this is amazing. And it just kind of gave me an idea and a bit of confidence. And it tied in with something that Mark Austin had said on one of the business sessions that the college provide, that, someone will already have your audience. Go to the people who've already got your audience. And I was like, where could my audience be? And then so I'm kind of putting things together and I thought, oh, we do have a cancer charity that I could approach. So I approached a local cancer charity. I got an interview in the April and I had my first client from them at the beginning of May.
Wow. I mean, that's quite bold, I think, because I do go on about all the research there is for doing, cancer support, but I hear very few people get into that area. I think they feel a bit, I guess maybe the Royal Society of Medicine lecture helped you with that regard, or because I think people feel, oh gosh, this is going to be a bit too tragic to work with. And these people have got real issues, not just a little bit of mild anxiety. I mean, there's real shit going. I mean, but you went for that. How come?
You're right. It was the Royal Society of Medicine thing. It was like I could see there's my training, there's everything I know. They're using it in this certain way. And there's all this research to back it up of how you can help with obviously pain, with hot flashes, with nausea, and I'm like, well, it's worth a try. It's worth a try. It's worth an email. And it's an area that you'd be doing, making a real difference. So, I just thought I've got nothing to lose. So we'll give it a go. And I was, afraid, maybe a bit strong, but I'm like, okay, this is, a wee bit out of my comfort zone to start.
You've only just qualified, and here you are working with cancer patients. I mean, that's bold.
Well, you've got to give it a go. But I suppose I had confidence in the tools. I'd seen them working. I knew what they could do. My case studies had been successful. I was ready. I wanted to take this forward. And yeah, although I was like obviously apprehensive, all of that disappeared when I started working with my client because, well, there was two clients in particular that stand out. The first one was a referral from the charity, and the second one was actively working with the charity. And they had a severe phobia of going for chemotherapy. But part of me is like, I know how to do this. We've been taught how to do this.
How to treat phobias.
Yeah. So do what you've been taught, do what you've been doing. Um, and I did. And it's actually the reaction of that client in particular that I think has sort of my journey has ended up going in this direction with pain. It's all of this that's given me the confidence then to approach pain because of how this worked. So when I first did proper hypnosis sessions with this client, afterwards she opened her eyes and she said, that was like time travel. I was there, I was in the hospital, and it was just like, whew, you know. And at that point, actually in the May, I'd also done the stress management and resilience building diploma. So I was almost ready to take myself down a path of doing purely sort of stress management, targeting education in schools, because I'm thinking, I've almost got a ready-made market here. I've got a route to market. I've got people's email addresses. I've got people that know me. This makes sense. Also, this is kind of what I should do. And there's the red flags, rather than what I really want to do. So if it hadn't been for that client, her response, and she responded so well, she went on to be able to do treatment. She had a hair loss phobia, which was sorted out in due course. It was just so successful, and the nurses at the hospital were utterly amazed in the change and the turnaround. So it's like my confidence was just, okay, we'll try this. And then, okay, that worked. Oh, okay, we'll try this. Oh, that worked. And just building from there to the point where I'm like, well, if I can work with cancer, if I can work with these situations, then I can pretty much work with anything.
Fantastic. All right. Well, I want to get into now your particular how your work has evolved now and this the particular work you work with chronic pain. But I just think that's just it's bold. Somebody put Scottish courage there. And you maybe also that's an aspect of interesting to was it also and in going to the Royal Society lecture recognizing that actually I've been trained and I have the skills to actually go in and do that. I mean, you could see what they were doing and you go, we've covered that. I know how to do that. Was that part of it?
Definitely. I mean, not only could I recognize my training in it, but I could also see, let's say, aspects of what was being presented that I'm thinking, I'm not sure the college would agree with that. Maybe, kind of maybe trance aspects of hypnosis and just things that wouldn't align completely. And I'm thinking, it was really powerful to see that and to think, well, I know just as much as has been presented here by an expert in terms of the hypnotherapy. So yes, that definitely gave me the confidence, but also being able to say to the charity, I've actually just been to this amazing webinar with the Royal Society of Medicine, and this is what they're doing. And that lends it a credibility as well.
Yeah, of course, of course. Well, let's talk about a little bit starting up in practice, a little bit on the business side, because that's an important aspect. People have to get that going. And then let's dive into your actual clinical work a bit. You started up in practice and how did you, well, so some of the clients you got through basically going to the charity. Talk to us about a little bit about how you find clients and how many clients you see right now and some of these factors here that I think are really relevant for people to hear about and then get some ideas and inspiration.
So I suppose everybody needs to find their way that suits them for marketing. And I feel, dabbled in everything. But my main thing was always my website. I've been basically been building a website since I signed up, signed up for the course. And I would say definitely don't do what I did. I'm on my third website build because I kept changing my mind. I started with Hebrides hypnotherapy. Then that changed to the therapy remedy, which was great. But then if I was working with people with cancer, you're not allowed to use the word remedy.
I can cure your cancer. No, I'm not saying that.
So that's problematic.
Yeah,
Um,
yeah.
so I had to then change again, and that was last summer that I changed to Living Well Clinic. So for me, marketing, like my top level is my website. And how do I get people to my website? So SEO, search engine optimization is my thing. My intention is to do more blogs, bring people in that way. Email marketing, I've started recently. I have tried paid advertising, so Google Ads, which did work well initially, before your website's really kind of in Google's system and showing up, that can be a good way to kickstart it. It's more problematic though for pain because you can't target health conditions with that sort of advertising. Certainly, I've found Facebook and Instagram just boosting a post to be very easy, cheap, and effective. And I would definitely recommend that route to people rather than Google Ads, which can be really expensive. And, I was like, had a tiny budget, just like testing, can this work? And even initially, sort of once things started going, once the new website was up, I was getting round about 2 inquiries a month. And I feel sort of more recently that's picking up now. So it almost seems like I must be really more embedded into Google now. I've also put more work into really optimizing every page, making sure that my search terms and my keywords are just right and that they're matching what people are actually searching for. not what I think is a good idea. So that certainly helps. So in terms of how many clients do I see from the beginning, let's say at the very beginning, maybe starting off one client, then that becomes two, then that becomes three, then it's four. Maybe by the December time last year, I was hitting 6 clients a week. And then maybe maintaining an average from then of around 5 a week on average.
And are you doing, is that you do I think you have a program, is it 8 sessions or 8 weeks that you see clients
I
over?
do have a program, so it's 8 sessions. It starts weekly to build momentum, and then we might taper off and just have them every
Spread it
two,
out a bit. Yeah, yeah.
yeah, or every
Very
month.
simple. Yeah.
This week, for example, I had 7 clients this week and 3 free consultations. So I feel like I'm getting quite like an uptick now, which is
Your
interesting.
sessions 60 minutes or 90 minutes?
The sessions are 90 minutes, and that's something that since I've been doing like focusing on pain, I just feel we need that extra time.
Hmm.
There's more going on. People have complex medical histories. There's a lot to say. People are going for appointments. They're updating you on all of,
Yeah, yeah.
their situation. So it just gives us a bit more comfort, and it gives me time to get to know the person.
And I think with these conditions that are medical conditions they're primarily working with, that they just don't get that time and attention from the medical establishment, whether it's cancer or whether it is whether it's a chronic pain and chronic back pain, or whether it's irritable bowel syndrome, or there's just not enough time for them to really tell their story and feel felt, heard, understood.
Definitely. And that was something initially when I started the program and I'm asking, clients, how does this feel? Does it feel right? Were those sessions too long or were they? And the feedback coming back was, no, I felt relaxed. I felt I had time. We were able to, do everything and we weren't rushed.
Mm. Well, let me just ask you about that. So you get feedback, you make sure you get feedback from your clients on each session, and because this is something we talk about quite a lot, and I'm interested to see how many people implement that.
I will be asking people as we go, like, and how was that for you today? Or how did you feel about today's session? I won't necessarily ask for, can you give me a number out of 10? But I will be kind of checking in, maybe not every session. And often though I'll bring back our original goals and I'll say, okay, it's been a wee while since we looked at these. Let's see how you feel we're getting on with these. And also, of course, at the beginning, I'm doing our clinical questionnaires, we're doing our screeners, PHQ-9 and GAD-7. I'm also at that point doing a brief pain inventory.
Mm.
So, taking notes on just briefly, like numbers on their pain levels, how it's impacting their life, how it's impacting their sleep, how it's impacting their mobility. And then I'm taking those measures again at the end. And I'm also taking a measure, patient global impression of change. And it's a score out of 7, and it's how much has this helped you? Is it kind of not at all, a little bit? Or yes, this has made a significant difference, or number 7, which is the top one, this has made all the difference. And I think I've only had one person give me number 6. Everyone else has been number 7. This has made
Wow.
all the
Wow.
difference.
And you're taking that score at the end or throughout?
I take that score is right at the end because that's considered the end of treatment review.
Okay, end of treatment review. And these sound like stuff. I mean, for everybody there who doesn't know, PHQ-9 and PHQ-9 is measuring mood, depression, and GAD-7 is measuring anxiety, and they're very, very well-known measures that are used throughout National Health Service. And people are trained to use them. But it sounds like you're using some other. So is that pain inventory something you built, or is that a standardized
No,
inventory?
it's standardized and you can get it online. It's just called Brief Pain Inventory, and it's very simple to use.
Okay. I think what will be super after this, Anna, is if we email everybody who's in this with any list of resources, we could put together the books, etc., and some other things like that. Maybe we could put a link into that so people can get that, because that sounds great and just so useful to have some measures in there. So before we get just a little bit more, so you were getting 2 inquiries a month, you said, from the website, but you did say to me that actually, because you're seeing people over 8 sessions, that was actually, it sounds like you're also, when you're getting 2 inquiries, you're ending up very often seeing them.
Yes.
Kind of. So, and then you've got 8 new clients a month coming in, and you're doing 8 sessions. So, I guess that's keeping the, and when you've got 3 inquiries a week, that's then going to be quite a lot now.
Yeah, I mean, I'm now getting to the stage where it's not panicking, but I'm like, okay, if these people come on, how's this going to fit in? But also have to remember, well, I've got people that are coming to the end of their time in their sessions as well. So, I may get to the point soon though where I have maybe a small waiting list. I can see definitely that could happen if things continue in this vein.
And how do you decide on 8 sessions? And do you still stay in touch with people afterwards?
I think, see, because you've got these sessions that are an hour and a half, you get to know people really well. And pretty much I'm in touch with all of the people that have done the program with me, and they'll get in touch and let me know how they're doing and how they're getting on, which is lovely that, they're keeping me up to date and, letting me know how their lives have changed and moved on and, what's happening. So it's really rewarding, obviously.
And nearly all your work is online, is that right?
Yes, I do have one client that I see in person. I've been seeing them for nearly a year, and even when I've had clients on the island, they've chosen to go online anyway. So yeah, I'm like 99.9% online.
So
I live in the middle of nowhere though, so that's perfect.
and obviously that works, for people that are, I mean, here we are working with a very tangible condition, pain, and we're doing it remotely, doing hypnosis over the internet with people, and they're experiencing this change.
Yep, it's absolutely doable. And sometimes people, sometimes clients will say, but does this work online? Can you do hypnotherapy online? And you're like, yeah, it's just the same. In fact, it's even better because you're in your own surroundings, you're more relaxed. You don't need to go anywhere. And particularly for working with a pain population, what really works is when people are at home. So often people might start the session in an ordinary chair, like we are now in their office chair. And then once we come to the intervention part, they'll maybe choose to go to an armchair. Or some people might even choose to lie down,
Mm.
depending on how they're feeling.
Somebody's asking here a little bit more on the business side, how much do you charge per session? But I think it's because you put a package together, don't you?
Yeah, I put a package together. The package for 8 sessions just now is £695, and that works out at £87 a session. And that might sound, oh gosh, that's really pretty good, or that's confident pricing, but I feel justified because it's an hour and a half.
Hour and a half. So you're less than £60 an hour there. And I think, of
Yeah.
course, you don't have any, you don't, if you're doing search engine optimization, you don't have any marketing costs apart from running your website, and you don't have any, the biggest cost generally for myself as a therapist was room rent, but you're not having that as well. So that's going straight to the bottom line there. Um, okay, well, that's great. And I mean, you said you kind of do about six sessions a week. Is that, and are you setting that as kind of the maximum? Because I know you're doing some other things as well. Um, is that because it's very emotionally draining? You do a lot of prep work for it. I mean, if you went kind of full time just on this, how much could you do per week before you'd say, I think that's about my limit?
Well, given given that I came from doing two full-time jobs
Yeah,
and I came into this to have a different way of life,
yeah.
I have to be very careful that I don't end up, because I do have that personality where I could just end up right. My diary's full.
Healer of the world, Anne. Yeah, from Stornoway.
So my diary's sitting here and I actually split each day into three. So potentially I could have three appointments per day. But I don't want to work every day. Ideally I would keep a Friday free, for example. And also I don't want to do 3 hour and a half sessions in a row. I'll do two a day. So I try and spread it out a bit like that. So for now that feels comfortable. And perhaps once I have more experience under my belt, maybe I'll get a bit faster. Maybe I won't need to do so much prep. I'm still at the stage where, you know, each new client is often a new condition and something I'll have to sort of go away and research and, want to feel that I'm fully informed about what
Give
I'm.
us a couple of examples of just that. What sort of new condition that is, and then how you're preparing for that. Because I know that, just when people start out, they end up spending like 2 or 3 hours preparing for their session. Then they get to the session and they go, and it all just changes anyway. And after a while, people realize they don't need to prepare that much for sessions. Somebody's coming with anxiety, they can be in the moment with a client. But this sounds different. Yeah. So tell us a little bit there about how you prepare for a session with a new client there.
So, well, for example, I had someone recently that I was working with burning mouth syndrome.
Hmm.
And I have no experience of that. I don't know anyone with it. So I want to be knowledgeable and understand what they're going through. So, yeah, I have to do a wee bit of research into the condition, what it involves, what it feels like. And obviously, they can tell me, but I don't want to be looking like I'm learning it for the first time, you know. Um, so, and for those of you that don't know, burning mouth syndrome feels like you've just rinsed your mouth out with boiling water. And the particular lady that I was working with, it was there all the time, to the point where even her own mum didn't believe her because this lady was still going about her business, still working, doing all the things, but just having to suffer, And she's saying to me, I could lie on the couch. She says, but it makes no difference, to the level of pain I'm in. So I may as well try and carry on my life, in some way.
I've never heard of that. And is that is there any cause for it? Or does it just seem to be what we might call a functional disorder or?
Sometimes there can be a cause, sometimes it can be hormonal, there can be things going on, but this particular lady had had everything checked. At one point we thought, could it be trigeminal neuralgia? No, that's been ruled out. So often the people I will see will have had lots of investigations, and it's almost like the end of the road. What's going to work for me. So in this case, we knew that there was nothing, no underlying cause. And this is another one that I remember as well, because this lady, this didn't change. Like, I think it was a solid 8 all the time, it didn't move. And then in one of our sessions, doing an intervention, it started going down, it started moving. And when we started doing the debrief, her words were, that was magic.
Well, what happened there? I mean, and have you just been trying different things to see what might work, or what was the?
Well, obviously, we can use our hypnotherapy tools, and we can use our pain control scripts, and we can use our suggestions. We have so many things that we can use for pain. In that particular case, I was actually using mindfulness and paying attention to the pain with one eye, as I call it, in a detached way. Because so often we're trying to get rid of the pain, which is natural. We don't want it in our body, we're frustrated with it, but it's almost a sense of, even for a moment, being in harmony with it, noticing what it does. Does it change? Does it move? Is there any flux? No need to change it, just need to observe and be with it in the moment. And it's really interesting just how much impact that type of very simple approach can have.
Having the person become just an observer of it, but also curious about it. I'm
Yeah.
very interested in the curiosity mindset, what that does to our experience. Um, Interesting. And a sense of distancing as well, or not? I mean, I do remember Dr. Hassan Aladdin. He always, did a lot of deepeners that would also all be about, I'm going to count from 10 to 0. With each number, you're going to become more peaceful and distant, more peaceful and distant. And I was like, he did like 3 in a row like that. And I was like, that's so interesting. We go, deep, more relaxed, but I never suggest this peaceful and detached in a way from your experience.
Yeah, there is a sense of detachment of one of the phrases is being the passenger in the car, or the same energy as if you were watching the clouds in the sky, that type of thing. But am I doing loads and loads of deepeners in that way? No. But one of my key techniques that if they're game, that I teach everyone really from very early on, usually session 2 is progressive muscle relaxation. And that is built in and continued throughout. And we do a check in with that as well. So we'll take it from a kind of longer session, sort of, well, if they're up for it, 16 muscle groups, if not 7 muscle groups. Then we'll take it down into 4 muscle groups and a much shorter session. And then we'll take it to sort of rapid relaxation through recall and counting. So it's not one and done, it's we're using this throughout. And that's what I'll use in when we're doing the hypnotherapy as well. So they've got this skill, and it's like, okay, let's remember what it's like when all of our muscles turn to jelly. Let's recall that in the body now. So we're kind of drawing on all of that.
Yeah, I mean, well, I'm a big fan of progressive muscle relaxation, and it sounds like you've dived into that a bit yourself because we don't teach you to do 16 muscle groups, then 7. You've dived into that track a little bit more, haven't you?
Well, I like to, especially because I've put a program together.
Yeah.
I want to be okay. Is there other things I need to know about this? What way will I go about doing it? And how can I make it, because it's a program, not a one and done, but this, in the same way that we train in self hypnosis, how can I train this in and make sure it's not just an audio that's then forgotten, that
Hmm.
it's a skill that they've retained and will use,
Implement, yeah.
all the time by the end.
So that becomes I mean, a simple pain control method for them is just to turn all the muscles to jelly and see how that changes their experience.
Yeah, it gives us an easy way in to start any of the interventions as well.
Yeah, I always find it very tangible as well. People don't have to be kind of psychological at all. Even if they can't focus, they can focus on this and then letting go. And so it's like a way of engaging and experiencing change.
Absolutely. One of the ways I sell it to people is, particularly if you're living with chronic pain, you're carrying tension, and sometimes you'll be aware of it, but lots of times you won't. You may even be holding and guarding and tensing wherever is sore. So we want to give you ways of releasing that, but also ways of noticing and becoming aware and noticing those early warning signals. So, for someone that's got tension, headache, or migraine, are you aware or noticing your jaw? That, like, those sorts of things.
Yeah, yeah. And well, yeah. And then we get into all sorts of things about early warning signs, the fact that pain isn't a 10 all the time, when we can dive into some of those principles. I'm going to have one more question I'm going to pull just from the chat here, and then going to have you present your things. Then we'll come back to the rest of the questions here. But one of the questions was, hi, Anne, do you have any specific process for intake, confirming with GPs, etc.?
My intake is actually it's my own version, but it's based around everything we learned on the diploma. So I have my registration form, as I mentioned, GAD 7 PHQ-9, brief pain inventory. What I do is have a very thorough sort of medical review of their medical history, making sure that this has been thoroughly investigated, thoroughly checked, what has happened, what's the current situation, and is it something I should be inserting myself into or not? And that I can understand that question and I can understand that concern, because at the outset you're thinking, am I going to be able to work with this? But honestly, mostly the people I am working with are almost, they have tried everything. They have been all around the houses. They have seen every doctor. They've seen specialists. They've been for scans. They've tried nerve blocks, injections, acupuncture, physiotherapy. Like, they've tried everything and nothing has worked. So it's almost like, well, this is does not cause any harm. This is gentle and natural. Let's see if we can help shift it.
So that they don't come along with a stabbing pain in their stomach and go, instead of seeing the doctor, I'll call up Anne. They do the rounds and get it all checked out. And then
Yeah.
so and from this aspect, they're arriving in a very interesting, because in some ways we might feel, oh my gosh, I've got to help the people arriving. And I think this kind of lack of confidence and also feeling a lot of pressure when somebody arrives with pain. I mean, that's, I think, what runs through my mind. I've done a little bit of pain control work, but I was aware of that for myself there, feeling that. But talk us through that aspect in terms of, one could feel like a lot of pressure and a lot of, oh my gosh, this is pain. And yet here you are working with people who are coming, I don't want to say they're desperate for help, but in some ways they are. You were saying they're just so willing to try something. Their expectations aren't massive. To talk us through some of that, because I think that helps reset our mind as therapists, that we can provide some help, even if it's just a foot in the door, and shift the experience somewhat.
Absolutely. I mean, I understand that apprehension, and honestly, I still have it. Every new client, every new presenting issue, particularly if it's something I haven't treated before, I'm thinking, okay, I hope I can make the same difference here. But I know that the tools work because they've worked with other people. It's just this condition is presenting slightly differently. And I think the more people I work with, the more people I treat, the more results I get, the greater the confidence becomes, because I'm seeing with my own eyes, yep, this is working. And sometimes, um, you know, it won't be like, oh, I'm all cured now. I have had a couple of people where, oh, I'm no longer a chronic pain person, or pain is no longer part of my day to day. But the aim is to leave people in a much better place than they were before. And the tools that we have, yes, of course, we're targeting pain, but we're targeting everything else as well. So quite often you'll find people are understandably anxious or worried, and we have the tools to deal with that as well. So you'll often see, I think it's your phrase, Mark, I use it all the time, a loosening of the shackles. That once one thing starts to go, we get this little kind of knock-on effect. I've got someone that I'm working with at the moment, lovely young man, it's back pain, and we're working with it, we're getting there, wee sticking points. But he also came in with huge anxiety. And I recently said, actually, I said, let's just redo your scores here. Because I think we're starting to see a wee breakthrough and his scores are right down. So
Anxiety scores.
anxiety scores. So I would say have confidence in the tools because they work, and almost trust yourself and trust the process. Whatever happens, they will be better off than when they come in the door.
Interesting. Even if one might, and would you generally go for anxiety reduction first before you work on changing the pain experience, or do you think they're just so interlinked? Because in some ways we might feel on stronger ground working with the anxiety, because it's like we've got such a range of tools for working with the anxiety.
I mean, we could, but when time is tight, I'm choosing very carefully what I'm going to target first.
Mm.
And almost sometimes I'll say to people, look, the things I'm doing with you here now, when we're teaching you to relax, this is not only going to impact your pain, this is going to impact anxiety as well. This is going to help you sleep better too. So I'm kind of emphasizing the versatility of the tools and how they can be used and why we're doing this, rather than that.
Beautiful, beautiful. Okay, let's dive in and let's have your presentation, then we'll come back and really make sure we get through all these questions here. But I want to honor the fact that you've put something together for people here. Let's dive through that, and then we'll come back and make sure we've covered off all the questions and try and finish by 9. See how we do. But lovely, just great stuff, Anne. I love it.
Okay, so share. And that's not right. That's my screen. There we go. Okay, is that working now?
Yeah, I think it's just going to take a little. There we go. There it comes. Yeah.
Yes, this is the Outer Hebrides Broadcasting Corporation.
From the Living Well Clinic in Stornoway.
Yeah. Okay, so I thought this was important. This is something I didn't know when I started this work, that up until fairly recently, there were two categories of pain. Nociceptive pain, that's kind of like your acute pain, hurt yourself with a hammer, trap your finger in your straighteners, step in a bit of Lego, have surgery, a bump, a bruise, broken bone. That's nociceptive pain. Neuropathic pain, that's like your wiring system, that's like nerve pain. So, but both of these have a physical or a structural cause. So, nociceptive pain, like issues in the tissues, and the nerve pain or neuropathic pain, kind of issues in the wiring there. But actually, there is now a third category of pain, but this only was introduced in 2018 by the World Health Organization. And this category is chronic primary pain. So this is where pain is the presenting problem. And if you can see it on here, basically starting at the left-hand side, we've got fibromyalgia, CRPS or complex regional pain syndrome. Then you've got all of your like tension headaches, migraine, face pain, trigeminal neuralgia. Then you've got IBS, bladder pain, pelvic pain. And then your last one is like musculoskeletal, so back pain, neck pain, limb pain.
Let me
And
just pause you here. Everybody, if you can't see the slides, you need to change your view. You need to go top right on your Zoom window and click view. And then you can look at the shared content only, standard side by side with speaker, but that'll give you the view usually. But you need to change your view because some people can see the slides, some people can't. It's the view setting you've got. Sorry, Anne. Go.
so that gives people an idea. And I would say, in terms of my work and the people I work with, it's mainly chronic primary pain conditions that I am dealing with.
So that's down the middle there, yeah? Oh, come on, let's come back to that.
Yeah, all of these.
All of these over here. Okay.
All of these. Yeah.
And what about some of these ones on the left-hand side? I mean, fibromyalgia, a lot of people interested in working with that. I always say, well, that's a complex one.
It is complex, but there's a lot of research around it now. I'm actually working with a lady at the moment with fibromyalgia, and these conditions, the pain is real, but a bit like IBS, we know there's a large psychological component to these. So even our tools can impact people's experience of all of these conditions. I mean, even the case study that I've got tonight is complex regional pain syndrome. That's possibly the most painful condition that a human could have. It's sorer than having your finger amputated without anesthetic. and it affects
Mm.
the limbs, so usually an arm or a leg, and it's a very intense and debilitating burning pain.
Wow.
So these all sound quite scary, but our tools can help this stuff. And that's hopefully what the case study will show you and kind of bring to life. And I talked obviously in the last slide about, if you have a broken bone or a bump or a bruise or an injury of some kind, that's nociceptive pain. But also here, when that type of nociceptive pain doesn't heal, it can then turn into this type of chronic pain as well. What isn't mentioned here, but is also relevant, is any type of chronic symptom that hasn't resolved as well. This can also be treated by our tools. So, chronic fatigue, for example. So, the case study, this is a lady, Caroline, not her real name, who was 64 years old when she came to see me. She'd really been forced into retirement, had been looking forward to this period of her life, had made lots of plans. She was a very, very active lady, doing coastal walking, dancing, gardening, volunteering. But then she started to suffer with pain in her knees. So she was advised to have keyhole surgery on both her knees, which she did. And then this ended up becoming complex regional pain syndrome. Not only did the knees not heal following the surgery, but it became worse and it developed into CRPS and this burning pain. And it's not only a burning pain, it impacts almost the circulation. There can be swelling, there can be obviously burning, hot burning or cold burning. There could be colour changes in the limb, extreme sensitivity. So this lady, for example, was wearing shorts permanently because she couldn't bear fabric touching her legs. And she had been unable to basically walk anywhere since the operation. So for about a year, she's been suffering with this before she comes to see me. She obviously, at this point, she has a pain consultant. They've tried injections, they've tried nerve blocks. And of course, there's a lot of grief around the life that had been planned for retirement, the plans that she'd made with her husband. But she was highly motivated and she had excellent family support. And she was also aware of how the mind can impact the body. And she also had had a previous recovery from chronic fatigue syndrome. So these were things for me that are kind of key indicators that this is someone who is, well, not only highly motivated, but has recovered before. So there's a message here of you've done this before and you can do it again. The other thing that's interesting is when she'd been on holiday, there were periods when she had no pain present at all.
Mm.
And if you're dealing with a condition that has a structural component, if there's an issue in the tissue, let's say, then pain can't just disappear like that. If you've got a broken ankle, that's going to be sore until it's fully healed. It's going to gradually get better. But it can't just wake up one day, my broken ankle's all better, and then sore again the next day. So there were some clues there. So basically, she signed up for the program. Now, these boxes are just a kind of loose, almost curriculum of the sort of things that we will cover depending on what the person needs. It's not a step by step or number 1 to 8. It's just giving people a flavour of the type of things that we might do. So, in terms of,
You want to talk through those broadly, or do you want to give just kind of we're looking at them going, oh, that's interesting.
Okay. So, well,
They'll
understanding
double click
pain.
on them, yeah.
Under understanding pain, basically, what is pain? Why are we having it? How is the brain doing it? How is it appearing in the body? Just a real understanding of your own body, your own brain, what's going on, and then how you can influence that through what I'm calling here brain training. But that's more of just really honestly from a marketing point of view. It really is almost, I'm referring really to mindfulness there is the tools I'm thinking of when I'm talking about brain training. Pain relief, in my mind, when I'm saying pain relief, that's me referring to our hypnotherapy tools and our bag of useful things. And then, of course, you're providing that emotional support for people. There's no getting around it. This is an at-risk population, people who are isolated. It's hard to tell people what you're going through. People don't understand. So they need that extra understanding and support from you,
Mm.
helping them deal with their thoughts and their feelings. Because, of course, all of the thoughts, is this me forever? Will I ever get better? What if this is my life now? I can't bear this. Giving them ways and techniques to understand, firstly, why their brain is giving them these types of thoughts and what they can then do about it. So, whether that's, dehypnosis, diffusion, or doing a thought record, for example, and decatastrophizing, that type of thing. We've got lots of tools to choose from there. Sleep and relaxation, because of course, if you're in pain, you're more than likely going to have trouble sleeping. Often pain will be waking you in the night, or you might even just have trouble dropping off to sleep. So, depending on how prevalent that issue is, that's something that we'll work on, more concretely, if you like. But often I would say what you find is it's like that house of cards, it's like loosening the shackles. If we get that relaxation in place, if we manage to make inroads with the pain, these things start to improve. A values-led life, so much of the life that you perhaps wanted to live, you feel isn't there, but we're trying to say, well, what can we do? What aspects do you still have? And how can we do that in your life right now at the moment? And what is it you want to get back to? And then really just the routines part, I think I call it recovery routines now, is it routines that will aid and maintain your healing or your recovery, making sure that these aren't just, I suppose, a bit like I said earlier, it's not one and done. It's not just I'll listen to these for 8 weeks. It's I'm going to come out with a suite of tools and ones that are adapted and work for me that have become part and parcel of my daily life to ensure that that I have a way to self-regulate, that I have a way to make sure that every day I am making my body and my brain feel safe and that I'm taking, my general stress levels are being discharged in some way every day.
Thank you. Wonderful.
Okay, so in terms of overview, everyone begins with a free consultation because I have to know, is this something that I can work with? And am I the right person for you, for your condition, or would someone else be better? Generally, most people are going for the program, so although it's 8 sessions, that might be carried out over 8 to 12 weeks. And some people may, at the end of 8 sessions, might choose to stay on for another couple or have another check-in in a month again or 3 weeks again. So I do have a few people that have chosen to stay on for longer. And some people do come back for other things as well. So we've already said it's 90 minutes per session. I think I saw someone in the chat asking about the format. The general format for each session is a kind of update on how has your week been? What progress have you had? One of the things we talk about in my sessions are the lovely moments. What lovely moments have you had? And these are the green shoots, the signs of progress, the things that are different now, no matter how small. And also unpicking your practice, your routine. It's not enough in this case, I feel, to just, are you doing your home task? Have you listened to your audios? We're unpicking that a lot more. What impact is it having? What did you find difficult? Really troubleshooting it because I want this to become embedded. Every session includes some sort of psychoeducation, whether that's about pain, about the brain, about how to deal with thoughts, about the pain fear cycle. There will be some element of psychoeducation there, and generally we'll be tailoring it to suit where they are in that journey. And then every session will have the kind of main or key intervention during that as well. And that will generally, I will record that live in session and then send that to the client afterwards. So don't worry, I'm not going to do section 1 to 8 blow by blow. I'll just give you a flavour, but the consultation is important because that's when I'm taking that full medical history that I mentioned. For me, for the population that I'm working with and those chronic sort of primary presenting pain issues, I'm kind of ruling out structural issues at this point, making sure there's nothing else going on. I'm also looking for neuroplastic pain, which is that third type of pain that we mentioned. Neuroplastic pain can be considered the brain is maintaining the pain. So why hasn't the pain gone away? Why is it still there? Even after, for example, an injury has healed. What's keeping it going? And the answer is the brain. The brain has learned to be good at sending pain. So we'll do a wee bit of that. We'll then obviously agree goals, do a treatment plan. So just exactly what you would learn on the diploma and what you would expect. One of the nice things, because my sessions are longer, I will always have time for relaxation at the end. I don't run out of time, which I used to when I was doing just an hour. So my kind of go-to there is Safe Place because that's just so versatile and because it's also obviously used in pain relief hypnosis as well. One of the books that I do recommend to clients, I have lots of books, but my kind of main go-to one in terms of pain is one called The Way Out by Alan Gordon and Alon Ziv. It's very accessible, very humorously written as well. So quite a light, easy read. And I mentioned that psychoeducation kind of runs throughout the whole, 8 sessions. So I'll be telling them more about neuroplastic pain and how the brain is involved. Of course, doing all of the stuff on the nervous system, fight or flight, regulating, all of these things that we learn on the diploma. I do a wee bit now around predictive coding, and that's around how the brain essentially decides whether or not to send pain. Do a bit, of course, around thoughts, feelings, behaviour. We do the pain fear cycle and how people can become very easily trapped in that cycle. And we do a wee bit about extinction bursts as well, because when we start to get resolution, sometimes people will get a kind of relapse or it will come back with a vengeance. But if we hold our nerve, then it can just be often an extinction burst. It's the pain checking. Can I give up now? Do we still need this behaviour? And the reason I'm doing that, I'm being one of Skinner's rats pressing the lever. Are you sure there's no food coming out here? We're just checking before we give up entirely. The pain does this as well. The pain will come back and check. Are you sure we're not needed anymore? I'm just double checking. So yeah, that's the kind of psychoeducation in a nutshell.
And we just wanted to, you don't do
Yeah.
gate control theory. We talked about this, you and I, Anne, which is interesting because you say you find it a little too complicated to present and people get their head around. Is that right? Or
I have done it in the past. I possibly would do it if I was just using hypnotherapy as a tool because it's quite clear about how, nociception, traveling from the area, up the spinal cord into the brain. The brain is then deciding at that point and potentially sending, pain signals back down. We're then able to close the gate. Almost, I used to describe it as a TENS machine in that same area. We'd be closing the gate in that area. If I was exclusively using hypnosis or hypnotherapy, yeah, I might just use that. And yeah, just find your way of doing it. I did end up with a slide eventually that I was happy with to explain to
Do share.
explain it
Do share with me.
if you like,
Brilliant.
to explain
Yeah.
what's going on. And these are key points as well that all pain is real, but all pain is also created in the brain. And while it might feel like pain is an enemy when you're suffering like that, pain is actually, it's there because it's trying to protect you, it's trying to help you survive, it's trying to keep you safe. Your brain, even if it's deciding to send pain, is doing it because it thinks it's required. But there's also a big but here. Pain is also your brain's opinion. So, how does your brain form that opinion? It's obviously got all of the current inputs going into it, your current thoughts and beliefs right now in the moment, the sensations in the moment, your nociception in the moment, the messages that are being sent, the signals, your emotional response to that, and your behavioral response to that. But that's not all. Your brain is also making this decision based on your prior and past experience, based on what it's learned about pain in the past, based on the contexts that you've previously experienced pain in, based on your expectations. If you believe that the pain is always going to come back, if you believe that this is always going to trigger my pain. All of that is tied into it. The situations and contexts, if it's stormy weather or if the pressure is high, then I will get a headache. If it's a certain time of day, this might happen. So we're actually starting to set up almost these conditioned responses, I suppose, these associations that the brain learns. So from this prior learning, this prior experience, the brain has all of this knowledge, but it's taking also what's happening now. And it's almost kind of rumbling them together and like 2 plus 2, do I need to send pain right now? And if you're in chronic pain, the answer is usually yes, because the brain's like, but this is what we usually do. This is what we're used to doing. This is what I normally do. And if we respond, what matters here is how we respond to that pain. If we respond to it as a threat, if we are afraid of it, that simply confirms to the brain, I was right to send you pain. I've kept you safe here. You've stopped whatever it was you were doing. So therefore, it's just reinforced the cycle again. I mean, there's whole books on this. This is essentially predictive processing, and your brain is filling in the blanks here. And it's making its opinions, making its predictions based on its kind of past experience and the program that it's running. And for many people in chronic pain, your brain has learned over time to become very good at pain, and it's very easy to switch that on.
And the thing we want to emphasize when you say your brain's doing this is making sense of the present moment experience based off of the past, that this is happening very fast and pre-consciously. This is not something that you're consciously doing. It happens before you're even aware of it. Your brain's kind of created that making sense of things based on past, right?
Your brain has joined all these dots, and you're not even aware of what it's doing. So then I would obviously, after or during that first session, set some goals. The way I often explain it to my clients is our outcome goal will be to, depending, caveat here, depending on their condition, to reduce or even eliminate chronic pain or chronic symptoms. That is like our Avengers Endgame goal. And then the way I describe it is, what we're going to do is we're going to set everything to safety. Your brain is trying to keep you alive. Your brain thinks that if you're responding with frustration or fear or worry or anxiety, that we're under high alert here, we're under threat. So therefore it's going to keep sending pain. So what we want to do is almost flip the switch, that our emotional reactions are safe, that they reassure the brain, that our behaviours are safe, they reassure the brain, that our thoughts are safe and reassure the brain. And when we're able to do those things, that will have an impact on the pain at the end. It's almost like if you've got an old-fashioned stereo and you turn down all of the dials to zero, you don't need to touch the main master volume in a way. That's the way I describe it initially. So those are our initial goals. So what does that look like in terms of key interventions? What am I using in terms of tools that we've been given on the diploma? I've already mentioned progressive muscle relaxation throughout. Also, always try and remember to check in with people during session. Like, right now, let's do a quick check in. Are you noticing tension anywhere in your body just now?
Very
It's
good.
just so they develop that as a habit themselves. Um,
Excellent.
I do quite a bit on mindfulness, so you'll recognise these as well. Leaves in a stream. Dropping anchor, I'm not sure if we refer to it as dropping anchor on the diploma, but we do it. It's, well, it's a version of it. 5 things I can see, 4 things I can hear, 3 things I can feel, and so on. Getting people to really be mindful of their surroundings, using all of their senses. Something I do use that isn't on the diploma, it's called somatic tracking. However, it really is just one of our tools with a different name. It's the equivalent of ABC exposure. But what we're doing here in this exercise is using mindfulness. People are almost exposing themselves to their own pain. So they're using mindfulness, just like we talked about earlier, to sit with and view their pain in a detached way, to notice it, to tune into their body, to see what's going on, to get, it's a form of acceptance. You're allowing it in, you're making room for it. You're you're paying attention to it with kindness, with curiosity. In those exercises, because it's mindfulness, you're not trying to get rid of it in any way when we're doing those ones. We're simply noticing. And that is surprisingly powerful. At the same time, you're kind of installing those cognitions of I'm safe, my body isn't broken, my brain is making a mistake, therefore I can recover completely. In terms of behavior, we're practicing being able to pay attention, being able to sit and notice the sensations in the body. And then in terms of feeling, it's emphasizing that feeling safe in the body. Also, I do quite a lot of relaxation, of course, but other ways of doing this would be lightening the mood with humor or with jokes to kind of offset I'm trying to notice my pain, but not too closely. Like, we don't want people studying their pain as if they're studying for a test. We want them to be relaxed and open, and humor is one way to do that. So then with these interventions, we do a bit of debugging and refining practice as we go. During all of this, people will have home tasks, so a daily diary to keep track of progress, how their own personal practice is going. We want to keep track of evidence of symptoms or sensations shifting in any way, no matter how small, and obviously those moments of progress as well.
Can you,
And
just looking
then
back there, when you said debugging, just to explain that to people a little bit, what you mean by that?
just really, how is this working for you? So for example, I'm trying to think of a good example. I had a lady this week who's been struggling a wee bit with safe place, and she said, I don't feel safe. And I'm like, well, why is that? Because anyone could come in. And I said, well, we could build somewhere that people can't come in. We can make it safe. What would feel safe? So she came up with a walled garden.
Mm.
So just finding ways that fit and resonate for the person and can work for them. Someone else, they were concerned doing some of the interventions about their concentration, being able to stay focused. And, we tried different things and they found that talking out loud about their sensations in the body in the moment helped, for example. So just tweaking things so that this becomes something that they can maintain and keep. Then sort of sessions 5 to 8, this is where the sort of familiar hypnotherapy, hypnosis scripts are coming in. Idealized self and script writing are big here. And what I'm creating really in conjunction with the client is almost what I call a recovery blueprint. What would this look like for you? What would we see you doing again in the future? What would it feel like for you? Getting them to really bring that to life. Pain control, of course, using the pain control script. Actually using, not in this case, but in other cases, healing white light I've found to be quite a good one to adapt for certain symptoms. So working with the pain, but also working with any obvious symptoms that are there. So for example, in this case with Caroline, if she had a shower, her legs and knees would all swell up and go red. So we did a lot of work around suggestions about the shower soothing and cooling, helping her circulation in the body, returning the colour of the skin to normal, her knees feeling like her knees again. So using that in a creative way to target, what are we still needing to shift here? Also, of course, for lots of people, and in Caroline's case, if they haven't been able to be active, we're setting behavioural goals at the beginning as well to get back to where they want to be. And sometimes that's in a very small way. So getting them to imagine what would this look like and creating, well, not a scary scale, but a hierarchy of, well, if I could just even make it to the gate or the end of the road or into town. So, in Caroline's case, her big thing was being able to walk to town and home again. That was her sort of main goal. She would say, if I was able to do that, that would be amazing. Also do quite a bit on thoughts and worries, and particularly in Caroline's case, she obviously worried a lot about her situation. It's a really painful condition she was dealing with, and nothing that had been tried by the medical establishment was giving her any relief or was working. So I'm giving her other ways to deal with those thoughts and worries. I suppose I use quite a lot of diffusion now, a kind of mindfulness-based approach to that as well, acceptance, noticing the thoughts. Leaves in a stream is a key one here for us, and and deciding, is this a helpful thought or not. I mentioned this already. When progressive muscle relaxation, we then keep it going throughout the sessions, and then we change it towards the end into a rapid relaxation. That means you're not having to do a half-hour audio. You can now do this by recall. And then again, if you've done a diploma, you'll be familiar with this, doing in the last session relapse prevention, creating a coping card, really drawing together, okay, we've done a lot of things. What's left now in your toolbox? What are you going away with that's going to remain a part of your daily life? And throughout these sessions, the kind of home tasks that I might be doing, the daily diaries continuing, might do some work around values, maybe some journaling, thought records, for example, that we use on the diploma. And one nice thing that I've sort of been doing often, if people are up for it, is writing a letter to their brain, and getting them to sort of make peace with the brain and say, thanks, brain, I know you're trying to protect me, but I've got this from here and everything is safe now, and look at the progress we've made together.
Lovely.
So, what does that mean, and what did it look like for Caroline? And how do I know if this is working? So, one of the reasons I'm getting them to keep track of these lovely moments, one of the reasons we're digging into all of these things is to make sure that they're working. So, it can be very simple at first, depending on the condition you're working with. So, one of the big wins right at the start was being able to cross her legs, because she had been unable to cross her legs for a year. Going to Marks and Spencer's and buying a birthday card, she was delighted. Now, to lots of people, that might seem insignificant or small, but it's not when you've been living in pain and haven't been able to walk. And then gradually she starts to get out a bit more. She's able to stand making the dinner. Her husband's not having to take over anymore. She's able to do the whole thing. This was big as well. She's coming in saying, guess what? I'm wearing tracksuit bottoms now. I don't need to wear shorts all the time. And my knees feel like my knees again. And then, of course, she's got times where she's realizing, actually, I'm noticing there's times where I'm not having any sensation in my knees at all. I'm able to clean for an hour and a half. I'm able to walk to the supermarket for flowers. Or her sister's grandchildren were climbing on her, and her words were like a ladder. And that was huge because previously the children were like, don't go on the couch, because Caroline would have to have her legs up and they couldn't go near her. And it's a massive change. No longer afraid of, accidentally knocking her knees together, that something might happen, being able to straighten her legs and touch her toes. And then one week she came in and said, almost apologetically, I'm really sorry, I've been too busy to practice. I was like, well, what's going on, Caroline? What's going on that you've been too busy to practice? Well, oh, I've been out here, there, doing this and that. I'm like, what, living your life? And she's like, yeah. I says, well, no need to apologise for that. That's why we're here. So, and she did. She achieved her milestone goal before the end of the 8 sessions. She walked into town and back, and she did all of the things that we had set up and discussed in her recovery blueprint, where she imagined walking to town, imagined taking the route going through the park, listening to the birds, having her husband at her side. She also worked in the garden without any sensation, and she was doing like heavy physical branch work as well. And Caroline has kept in touch with me, and she did sort of 4 months on from the beginning of treatment. She then went on a coastal walking holiday and sent me a photo of her on the coast doing her walk. And she sent me a message saying, last week I started back at the gym, a very slow pace to try and build up some muscle. So the lovely moments have become huge, and I'm starting to enjoy life again. I don't know how it can be any better than that when someone can get their life back. You know, yeah.
Beautiful.
So that's it. Thank you. I feel like I've talked a lot there. I felt like I was rambling. So,
Not at all. Not at all.
um, yeah, I'm on LinkedIn. I'm on Instagram. I'm on Facebook. I need more pals. Please, please connect with me there. Uh,
Yeah, go check her on Instagram now. Prerna, that was just really, what I loved it. You make it so clear and so simple, and the Scottish accent is fantastic, and and all the whats and you get the H's in the whats and the whys, but but no, really beautiful. And I just really impressed and just love the way you've put this together. And again, your material is so clear. You're so clear in the way you communicate as well. And I'm sure that's not just here. I'm sure that's with your clients as well. And that's, well, you're an educator down at heart, aren't you?
Well, do you know, I do use slides with my clients. I do use visuals with my clients. Um, it helps keep me right, particularly with some of the psychoeducation and some of the trickier aspects. And I think it helps bring it to life for them. And often clients will say, "Oh," or you'll see them, making notes. And I'll say, "Look, I can send you the slide handout." And like, "Oh yes, that would be great." So
One
I'm
of the
not, I'm not.
benefits of working online, isn't it? I mean, that you can access these materials, present them to people, even show them something on the website or YouTube or whatever, very, very quickly, which would be more clumsy to do in an in-person session.
Yeah, it's funny. I do when I do my one in-person session, I miss the facilities that I have, but it's good practice for me actually to almost be unplugged and just, practice doing it without any of the tech. But yeah, I do find it useful with the slides, and I think clients do as well. It was actually a client that inspired the me working in that way when we were doing their it was a case study and we were doing their treatment goals, and they were saying, "I'd love something that was written down. Could you send that to me?" I'm like, "Okay, I need to find a way of doing this that's easy to do at the time and then easy to send when I finish, so I'm not duplicating work or having to go away and create a PDF for them."
Yeah, great. Yeah, it's so efficient and effective if you can do that and make the recording in the session from the session, and just be kind of figure that out. And then they get it immediately afterwards as well. So fantastic. We're going to go through. We've got a little bit. If we're okay, we'll go over just a few minutes with some questions here. And I just want to have one thing that came up for me, which I'm interested to ask about, is the nature of hope. And then obviously when we read that book, Persuasion and Healing, Jerome Frank presents, as he says, the essential thing that people present with across all situations and all types of psychotherapy, and he gives a very broad definition of psychotherapy, is demoralization. People arrive and they've lost hope. And so it was interesting. I was talking with my daughter, and she's doing research with people with young people with Parkinson's. That means people under 50 with Parkinson's. She's working at Queen Square, part of UCL, and she said they don't talk about dopamine, they talk about hopamine. And that
Oh,
hope, I just love that. Instead of dopamine, they talk about hopamine, and that hope is such an important thing for someone with Parkinson's, particularly a younger person with Parkinson's. So, can you speak to the nature of and the nurturing of hope, and how people arrive and how they leave, and all the progress through with your clients?
yeah, like when people come to me because they've tried everything, they want to believe, they want to hope, but they're absolutely terrified of putting their hope in something else
Mm,
again.
mm.
So it's like they're in two minds. And there is a lot of kind of reassurance and almost like, well, borrow my confidence. Like, I don't know what this journey is going to be like, but I know that you will be better than where you are right now. And together we'll unpick the journey. And, and I'll say to them, you don't have to believe 100% right now. You just have to be open to this. And I say, that's all we need. And once we start the work, and once you start to see those little changes, then you'll start to have confidence. Then you'll believe. Then we'll start to get some momentum. And then we'll start to get into a positive loop because now you'll see this is changing, this is making a difference, and I want to keep going with it.
I love that. Borrow my confidence. That's beautiful. That's so beautiful. And what just came to mind for me there was also, I don't know if you saw the interview I did with Denise Iodash, and she said this lovely thing. She said, fundamentally, I sow doubt and I sprinkle hope.
Oh, I love that, sprinkling hope.
And sowing doubt about this pain being a permanent thing. We're going to loosen that up, possibility of change and then sprinkling hope. Just fantastic. Let's have a look at some of the questions here in the Q&A. Martin said, I found my GPs useless in addressing my own chronic pain. Is this a common problem in your experience?
Yes, absolutely. Unfortunately, sadly, the kind of pain science is there, but GPs are not up to date with it, generally speaking. And it's a shame because they're pushed for time, they're working within a system, a bit like schools, things are limited. But yes, and most people will have had a less than ideal experience. In saying that, actually, I was speaking to someone today who said his three GPs have been amazing. So, I think things are changing. But, feel free to get in touch if you want to know more about whatever type of pain it is you're dealing with.
I think I mean this basic psychoeducational material about the possibilities of change of the pain experience, whether it's with that more sort of neuroplastic approach or gate control theory, that this information just isn't shared out there much at all. It's just, and doctors don't seem to, even though they could probably introduce it even in a 10-minute consultation, they could start to give some possibilities. But I was watching a BBC documentary on chronic pain, and it was clear people aren't presented with this information much at all. When they start to see it, they go, oh my gosh, I can at least make some change in my experience, maybe.
Even in my own experience, I feel like they were looking back now, knowing what I know now, looking back, the consultant said to me, it's just that you're extra sensitive, that it wouldn't be sore for someone normal, but your system is sensitive, so you're experiencing it more. And I think, okay, that was the beginning. Like, it wasn't even a window you opened, like, but it's not enough. That wasn't enough to set me on the track of understanding what you were trying to tell me. So yeah, there's work to be done, and there are people on the case, trying to communicate this science to GPs as well.
And I think, to think about the bigger themes here as well, this is about giving people some sense of agency over an experience of where they are not feeling agency.
Absolutely. And one of the best things that people say to me, at the end of 8 sessions or whatever is, I feel I have the tools now to continue this journey myself.
Self-efficacy. It's the big theme, isn't it? The self-efficacy. So Gareth asks here, I suspect that sphere of competence will be a determining factor, rightly or wrongly in my assumption, in people not working in pain. It's of interest to me amongst other things. So I'd be interested to hear if this talk tells me I'm wrong. Well, I mean, when we present sphere of competence in stage one, we do list that working with pain is something, providing it's been checked with the GP and that you're not working with undiagnosed pain, that there's been an attempt to diagnose it and it's found that it isn't related to a structural issue that needs attending to, that it's actually something you can start to work with. So do you want to speak to that? Because, in terms of working with, more moderate or severe mental illness versus, is this something that people, I mean, you started working with it quite soon, didn't you?
I did do one of my case studies was on trigeminal neuralgia, and I checked that out with my supervisor at the time, and I said, I'm really keen to do this because one of the areas that I'm interested in working in, I want to see how I get on with it. So yeah, that's if you're interested in pain at all, it just gives you that confidence of working with a client. It's not a paying client. So just getting that practice. I mean, there's no shortage of people in pain. Like 1 in 5 people are dealing with some sort of chronic pain. Someone, if it's not yourself, it'll be someone you love or someone you know, someone in your circle that, you're able to say, do you want to have a go at this with me and just see what happens?
Well, and that's a great tip I want to say to everyone. Don't just kind of do your case studies and then think, I've got to see paying clients. You can spend the next few weeks doing some more non-paid work to build up more experience, have supervision through that as well. And in that way, you can get some real experience working in the area you want to specialize in, non-paid basis. And very quickly, you'll begin to see you've got a whole massive suite of tools that can come in here and work at all these different intervention points, right? In this sort of complex experience, yeah, that they're having.
I can see absolutely why pain might seem scary for people, but honestly, the diploma has given me everything I've needed. It's basically, I'm just taking all the tools and focusing them onto just working in this area. But the tools are the same.
And this aspect of predictive processing or the predictive brain is something we're going to be, we've started to update through the course. It's already there, but there's more we can do on that, I think. So we'll be updating also the module on pain around that a little bit more. Martin says, what resources would you recommend for specializing in this area besides the course materials and the two Jensen books? Well, you've already got some good stuff there with the course material, the two Jensen books.
Well, that's what I was about to say. You've not left me not much left to recommend. Those would be my top things. Like everything we have in the diploma is absolutely there. And the two Jensen books are great because they have all of the scripts as well. It just gives you a bit more meat and you see his approach to it. Um, I'm struggling there. Some of the stuff actually it's probably on the hub. I think it might have been one of the ones that Rachel did. It was one of the mindfulness series, and I think Ron somebody is the man in the video, and he's working with mindfulness and chronic pain, and that will give you, although we do mindfulness obviously in diploma, this will let you see what does it look like when you're doing mindfulness but paying attention to pain.
Oh, Monica's just, hi, Monica, welcome. I remember you. She says, I can recommend Cognitive Therapy for Chronic Pain by Beverly E. Thorne, a step-by-step guide. Lovely. So that's a little bit more. So we've got a little bit more recommendation on the mindfulness side there, something also on the cognitive side. I would say a very interesting book, and you didn't mention this in there as an approach, but I would really encourage it. You might want to try this out, is The Open Focus Brain by Les Fahmy. And this is using particularly spatial awareness and also moving from focused attention into defocused, wide open attention. These have a profound effect on our experience, and that pain is a highly focused experience. And once you start to defocus and learn how to let go of focus like that, it diffuses everything, including any so and spatial awareness again is extraordinary for calming down this very stressed state. Let me put that in there, the open focus brain. And we do mention it a little bit in the course, and but I just love that. Unfortunately, he's passed away, and his wife, who took over his approach, has retired, and the daughter who's taken over the approach isn't that confident on delivering trainings. If you're listening, please do get in touch with us, because I have wanted to source some training on this particularly. So the Open Focus, Brain by Les Fahmy. Just a great little book with a recording in it as well. But yeah, I'm so just love this work you're doing here, Anne. So Tony Callahan says, hi, both. My question would be, if the pain in question is related to a structural problem in the body, joints, pain, or injury, by minimizing or nullifying the pain, would that not risk further long-term damage or related issues if the damage is left unchanged?
I'm not sure what he means by nullifying the pain. Do you mean like getting rid of it entirely?
Yeah, let's say that person's really hypnotic responsive, you can get rid of the pain entirely.
Well, if it's a structural condition, I wouldn't be going into it with the aim of getting rid of it entirely. I'd be going in with the aim of reducing the pain because, well, pain is a protector. We need the pain to protect us. And if there's a structural issue there,
Yeah, we need those warnings.
yeah, we can't get rid of hypnotize out the warning signals, then we're in trouble. So yeah, that's why you have to be, that's why I do the free consultation. That's why I do the full medical review. So we're quite clear on, is this structural or not? And that will determine which route you take in terms of the treatment plan.
Okay. Anonymous attendee says, I've seen your singing bowls in the background. Are these something you use in your practice with pain?
Um, I don't use them in my practice because I am working online, but two of the bowls apparently you can use them on the body. You can, place them on the stomach and use them there, but they're purely for my personal use. My
Okay, great.
play. I play with them. I'm not. I don't know what I'm doing. I just like the sound of them.
Geet says, what was it like preparing for and seeing your very first chronic pain client? Were you nervous? How did you plan that first session?
Do you know, I can't really remember the very first chronic pain client. I think I was more nervous about my very first client, when it's your first
Yeah, yeah.
paying client. And then once you've got them out of the way, it's like, okay, we're oiling the wheels. I just need to refine as I go. And I'm still refining as I go. You know, yes, I was nervous, but at the same time, with my first client was actually a singing phobia and
Oh, singing.
singing. They were afraid of singing. So it was a gentleman, I think he was 60, and he'd had an incident at school, at secondary school, where a teacher had said something derogatory to him about his singing, and he was singing in front of everyone, and he had never sung since. And this really bothered him because he loved music, he loved singing, he was a
Oh,
musician,
oh,
played the guitar. And even if he was at a wedding or a funeral, he would not sing. So this was something he had carried, and he decided, I'm going to solve this. I'm going to go to the local choir group because I can do that. And he psyched himself up and he went and he had a terrible experience and he basically shut down. And all he could do was just sit there. He couldn't move, he couldn't leave. And then that's when he came to me. So a phobia he's had for 50 years and did a free consultation. And I remember running through to my husband and saying, I know what to do. I know exactly what to do. And being so pleased and excited. So, yeah, I was nervous, but I was also excited that actually I know what to do. I'm not stuck. And that was so interesting because he was sorted in 3 sessions. Honestly, session 3 was already done. It's already sorted.
how fabulous. What a lovely confidence booster. I do think there's a little bit luck of the draw sometimes in the first one or two clients that you have. And sometimes people seem to get a client that looks like a simple case and it ends up being a really complicated case, their first client. And that can be a little bit tough because I think this step-by-step building confidence with simple cases is really important.
I
Really.
felt my case studies were all ended up being quite complex.
Mm.
Um, so I felt like almost okay, that was good. I got I got a wee win there, a wee easier one. But what was really interesting about that client was he actually got in touch with me, and was it in January, to say he'd been headhunted by his local choir, like not just a wee singing group, by the actual choir.
Fantastic. What a lovely story. Okay. Somebody says here, which client patients would you exclude and not see?
I think it depends on the condition. I did have a free consultation with someone this week with a really severe case of chronic fatigue syndrome, stroke, ME, and
Mm.
the kind of origin was long COVID and it had developed into this. And the person was now has been bedbound for a year, over a year.
Wow.
And I haven't currently worked with that. So once I kind of got more information, I said, actually, I think you might be better working with someone who has personal recovery experience of this, because there are people working in this space
Yeah,
who have personal experience of this, who are also therapists or coaches. So I put a call out into a network that I'm in and said, anyone here able to help? And I've referred it on there. So I haven't just taking everything. I will only take it if I'm confident that I can make a positive difference and that I'm the right person to do that.
and how long's that pre-initial assessment?
The initial assessment is advertised as 30 minutes.
Uh-huh.
Um, and sometimes it is. It'll be 30 minutes on the dot. Other times it will go longer, just sometimes because of the nature of the condition or the case or what people are dealing with.
It's very generous for you doing that free 30 minutes, I think, but it's quite a lot of time.
I feel it's necessary in that area because
Yeah.
I need to be sure that this is the right approach for them, that I'm the right person, that the medical stuff is all squared away. So, it kind of goes both ways. We're both kind of, is this the right fit?
But it also jumpstarts the therapy, doesn't it? Because you've got 30 minutes, you've built the relationship already, lots of good stuff going on there, right? So that's going to make that first session really roll along.
Definitely.
Yeah, yeah.
Yeah.
Um, somebody said, well, we shared session structure in process for intake. Do you work with all conditions? I think we've got that. So you don't, Garrett, Georgia was asking, do you take scores every session, on pain and everything, or more across a few sessions?
No, I don't take scores every session. Generally speaking, I'll take scores on intake and then scores at the end, unless I have a reason that I'm like, okay, I really want to check in on you and how, like your anxiety levels, for example. But usually just beginning and end. And in terms of pain scores, sometimes people will get clients to keep a pain diary and keep their pain scores. I actually stopped doing that fairly quickly and switched it to focusing on the positive differences that you're seeing. Because when people are keeping a pain diary and keeping pain scores, it's keeping them hyper
Turning to, yeah.
focused on their pain.
I think it was very interesting. I had some root canal pain, and it would come and go, and so it would be gone, and then somebody else would be telling me about their pain, and suddenly my pain would shoot back up again. So I was like, "This is so, just so, really badly," and then it would go, and I thought, well, it's very interesting. I love, Mike and Bam says nothing's ever a 10 all the time. And I think that to me, that's always the doorway in, for any presenting thing, is to say, well, it's not a 10. So when is it less? When is it more? What are the factors? And as soon as we do, you can take any condition and basically start to work out, when is it less? When is it more? Doorway in. But the other thing is to give a suggestion. And now you begin to notice more and more the times when you don't have pain. So I just thought, because they don't notice that, they notice when they do have pain. But no, you begin to notice when you don't have pain. You become more aware of that. You value that more. So I think that's just such an interesting shift. Such an interesting shift, which is reflected then in the way you're keeping scores of that. Somebody asked him, we will wrap up in a second, do you or can you use any of the tools on yourself?
Yes, I do use the tools mainly for relaxation. The reason I'm so passionate about progressive muscle relaxation is because the difference it's made for me.
Oh,
Um,
really? Oh.
I'm a headachy person. I'm now, and I'm still learning. Like I'm still noticing times where I'm holding tension. Silly things like when I get into bed at night and I've got my book, my feet are like this, rigid. And I'm still getting into bed, noticing and relaxing them. It's really strange, and I must have been just doing that forever and never known about it. Or times I might be eating dinner and I'm like, why are my shoulders up here? Or even like when I'm waiting for, a client to join the Zoom. I'll be doing a wee check-in. I'll be allowing myself to go all this like jelly. I'll be checking, where have I got tension right now? That for me has been the most useful. And the rapid relaxation that I teach to my clients, that's my kind of go-to practice. You can't see my chair, but if I'm sitting in my chair, I'm doing the short version of PMR, counting. So it's a kind of combination of counting the breaths, like Benson, combined with PMR and allowing everything to go soft, loose, and limp.
It's well, I love that. I do say, I think it can be a whole journey of self-discovery and self-inquiry just into your own tension patterns and kind of in some way making the unconscious conscious in that way. We don't have to discover the root causes of why we're holding tension in our feet in bed. We can just notice it and then realize we're doing that. And then, and this aspect of making unconscious doing, conscious doing, and then letting it go. And what is letting go? I mean, I think that's, I say, it begins with your muscles and ends with your soul. You learning to let go, what it is to let go. Yeah, a deep and fascinating journey, but simple, not complicated. Lovely. Okay, I think is there any final questions here? Else we're going to wrap up.
I'm glad I'm not alone, Druselle. Druselle does the feet thing.
I'm still noticing, why my shoulders are creeping up and tension in the jaw and just, yeah. Do you send transcripts to clients?
Transcripts of, no, I don't. If I send them anything, they'll get their audio and they will, not everyone, if they are taking notes and that type of person, I will say, would you like this slide handout? And I'll send that to them. I do send worksheets to take note of certain things, like their lovely moments, to keep track of their practice, to create a daily routine, but no word for word transcripts.
Fabulous. Well, loads of people thanking and beginning to sign off now. And I want to, thank you for this as well, Anne, because it's been really inspiring for me and inspiring to see you take this and create this your own thing here from the tools of the training. And and the way the progress you've made in your own practice there, it's fantastic what you built and the ability to share it so clearly and so confidently with other people here. So really, really good. And the Scottish accent, it's just, see, I trained with Donald Robertson. So it's not this, it's a little lower, his voice, but everything was about with James Braid and can just hear his Scottish accent going through. So lovely, lovely.
Oh, thank you. It's been such a pleasure to share the journey, and it is a journey when you do the diploma. Like, from the outside looking in, if you were able to look into my house, you wouldn't think that much has changed in my life, but everything has changed. Yes, I'm still here, I'm still at my computer, I'm still in my office, but everything has changed personally and professionally. And probably everyone's logged off now, but I just want to say a big shout out to all the people, all the new colleagues, all the new friends that I've met during this process. Thank you for the support, the encouragement, the lovely messages that people have sent me today, wishing me luck for tonight. And can't tell you how much that means. Sometimes people worry about this being perhaps isolating, working alone, being on Zoom all day. But I have made genuine friends and colleagues through the diploma. I'm in, I think, at least 3 very lovely, active and supportive WhatsApp groups as well. So thank you, and haven't been able to reply to anything tonight, but for all the supportive comments in the chat as well. Really very much appreciated. Thank you.
Well, and I want to just very selfishly say thank you that I got the chance to do this with you, because ever since you wrote in that first little essay, I've wanted to have a chance to, like, I know you were on the webcast and, I was teaching, we had a chance to chat a little bit, hear your story a bit, but the chance to actually really go to town on your whole journey and what you've been doing and everything. Lovely. Just beautiful. So keep doing it, and it's fantastic. And maybe we'll look at do some more sessions. And if people are interested in some more stuff on pain, let's get into that, because I really, really want to encourage people to do that. What greater thing to help alleviate human suffering, alleviating pain. Yeah. And
Yeah.
the power, and what I love as well is, bringing hypnosis in so powerfully into doing that and returning to that. So fantastic. Okay, thank you so much. Let's go have dinner. Good night, everybody, and thank you for attending, everybody. It's only great because you're here attending and listening and with your questions and everything. So good night, sweet dreams. And yeah, should we put together an email? I don't know, over the next couple of days and send that out. And if you've got anything you want to add in, I'll put some things in, but maybe you should give a little list of resources you might want to point people to. Then we can do a real nice follow-up for this.
Will do. Okay.
Fantastic.
Thank
All
you
right.
so much.
Thank you
Thank
so
you.
much. Good night, everybody. Take care. Good night.
Bye-bye.
Bye. Oh, just to remind anybody that's still here, you're all leaving now. I'm doing a Q&A tomorrow, Friday lunchtime. If you want to drop in, this is particularly for people who are still thinking about taking the course. So do drop in. See me tomorrow, 1 o'clock. Send the link round for you to register for that. Good night, everyone. Take care.